So welcome everyone. This is the topical webinar, Understanding Harm Reduction and Opioid Response. This is a partnership between Aurora Health Alliance and Adams County Health Alliance. Thank you for joining. My name is Jo Glaviano. My pronouns are she, hers, and I'm with Aurora Health Alliance. So I'm going to stop sharing and ask our speakers to introduce themselves. So we're going to start with Jennifer Mackender.
Hey everybody, I'm Jennifer Mackender, she, her pronouns. I work for the Colorado Consortium for Prescription Drug Abuse Prevention and External Relations for the Northeast region of Colorado.
Thanks, Jennifer. And then Elicia and Kit from Arapahoe County.
Yeah, hi, my name is Elicia Chacon. I use she, her pronouns. I am the program supervisor for the harm reduction team with Arapahoe County Public Health.
And I'm Kit. I use she, her pronouns, and I am a health educator for Arapahoe County harm reduction.
Great, thank you. And then representing Adams County, Ellen, Kelly, and Jody.
I'm happy to get us kicked off. My name is Ellen Velez. I use she, her pronouns, and I am the Harm Reduction Program Associate Manager with Adams County Health Department.
Hi there. Sorry, I was just walking from one meeting to another.
Okay.
Jody Nowicki. I am the Senior Director of Collaborative Action with the Rocky Mountain Partnership and facilitating the Adams County Opioid Abatement Council.
Great. Thank you, Jody. So I'd like to turn it over to Jennifer Mackender.
Well, thanks for having us. You have the heavy hitters of your counties here today to talk about the opioid crisis and the response. So it's great that we could all share time together. I'm just really here to kind of set the stage. Some of you maybe already know all of this information that I'm going to be talking about in the beginning. And for some of you, it might be new. So feel free to interrupt, all of you that have been working on things like this or presenting. Oftentimes we can't see your hand or see you if you have a question. I'm really comfortable with you just hollering out, say, hey, stop, I wanted to ask you something. So again, I'm Jennifer Mackender. I work for the Colorado Consortium for Prescription Drug Abuse Prevention. You can go to the next slide. So the Colorado Consortium is a statewide agency, and we really are here to coordinate the response to the opioid overdose crisis. We started this mission in 2013, and it was really in response to Governor John Hickenlooper at the time, the state's concern over response to the opioid crisis. So it started as an interagency and interprofessional response, and since that time has turned into the consortium. We're housed at CU Anschutz School of Pharmacy. Mission to reduce drug misuse by developing policies, programs, and partnerships. I work in external relations over there on that right side of the map. There's 4 of us that work on the ERS team, and I am in the Northeast region of Colorado. So I really have all of the Front Range area, as well as the Northeast rural counties out to Nebraska, up to the Wyoming border. And my job really is to get to know the communities and the counties and to support you in your response to the crisis. Some of the things I might do are participate in the opioid councils that we're going to talk about today, meet with the harm reduction experts, meet with people who have living experience, different organizations to help provide strategies, experiences from other counties, help connect people to funding, and really just help coordinate what we need to do right now in response to the crisis. And another piece of our work is really learning from all of you about what's going on and taking that back up to the state level to have conversations, and in particular around policy changes. Let me switch the slide. Here are our work groups. So another big piece of our organization, and we're very small. I think there's maybe 12 of us on staff. I don't even know because most of us are external. So we're never in one room together. But we do have program managers who oversee these work groups that you can see here. So we have the work groups really are, again, a response to the crisis, and they help execute and determine the strategies of the consortium. So our co-chairs are volunteers and partners of ours across the community. They can come from partner agencies, state agencies, such as BHA, CDPHE, and many of our nonprofit organizations and folks with lived experience also help as co-chairs. And so they get together as co-chairs and with our staff and program managers and talk about what they want to work on this year, and have these meetings either monthly or every other month, and they're virtual and anyone can attend. So even if this is something that you think that you cannot commit to joining, but you're really interested in the topic and learning more about the crisis, feel free to go onto our website and you can sign up to be a part of these work groups. And at a minimum, you'll at least get the minutes to learn more about the response to the crisis. So we're going to do just an overview of kind of how we got here. And I want to say that understanding the opioid crisis, I know it goes back way before the 90s, and I want to acknowledge that. The reason we started in the 90s is really because of the conversation where the settlement has come from, and that becomes from the overprescribing of prescription opioids in the 90s. But I just want to acknowledge that as we move forward. So the next slide will show you that we really talk about the crisis in terms of 3 distinct waves. So in the 90s, overdose deaths involving prescription opioids were increasing, and this was occurring because of pharmaceutical companies having large-scale campaigns to increase the prescribing of opioids for pain. Many of you have probably watched all kinds of shows on Netflix, et cetera, that have told this story. Some of them do a great job, some of them, overdo it, but they do a good job of explaining that, this is where this crisis began with the overprescribing of prescriptions. So then we go to 2010, and at this time, we knew that these pharmaceutical companies were overprescribing, and then we put the reins on our prescription orders. And this left people who were having addiction to these opioids and with nothing to do. So that's when we started to see the increase in overdoses from heroin. Some of the notes that I've taken show that I think it says there's a 286% increase in US heroin use between 2002 and 2013. And 80% of heroin users reported misusing prescription opioids before turning to heroin. This brings us to 2013 and moving forward. This is the third wave, and this is the rise in synthetic opioids, which we all know as fentanyl. This really happened mostly because heroin being something that's made in the earth, right? That the environmental factors were impacting heroin production, and the price of heroin began to increase. And so synthetic opioids were cheaper and stronger. And here comes the rise of fentanyl, because that's what our people who are dealing in these horrific drugs wanted, is something stronger and cheaper for them to continue to impact the United States, I'd say. Keep in mind that fentanyl is 50 times stronger than heroin and 100 times stronger than morphine. So here's the third wave. If you look at this, I can't say orange and green. I'm not colorblind, but when I see green, I say orange. So you caught me. But you see the green line there. This shows the third wave. And you can see that increase starting around 2015 and spiking up in 2020. And this is United States. These are United States graphs. As previously mentioned, the source of this increase is primarily fentanyl. You can see this first wave over here. I'll just give you a minute to look at it, the gray. These are your prescription opioids. So if this graph went back, you'd see the spike in overdose rates from prescription, but you see this start to taper off as the third wave and the second wave start to grow. So according to the CDC, these are CDC numbers up here. So again, United States, 69,061 deaths in 2020. Skip to 2022, 82,807 deaths. In fact, the CDC, when they looked at their 2022 data, it showed that 90% of their overdose deaths involved a synthetic opioid such as fentanyl. Another thing, according to the National Safety Council, Americans are more likely to die of an accidental opioid overdose than in a motor vehicle crash. It's also greater than the odds of dying from a fall, a gun assault, pedestrian accident, or drowning. So number one killer of ages 18 to 45. If you click one more time, it'll fill in that bottom box. And more than car accidents, suicide, COVID, and cancer. And I know these are a lot of numbers, and I don't mean to be presenting it that way. These are people, these are human lives. But it just shows you this humongous increase in our overdose deaths. And another thing that we always like to really point out with this slide is that when you look at all these other accidental deaths here at the bottom, these are things that we talk about, right? And I guess they're not all accidental, but deaths. We talk about these comfortably, usually. We have normal conversations about this, but we're not normalizing conversations around substance use disorders and overdose. So our goal is that, whatever you take away from the presentation today from any of us, please share that with other people and start having conversations the same way that I think, are doing a better job of talking about mental health. We need to do the same thing about talking about substance use and treatment and recovery and hope. So these are some Colorado data that just came out from CDPHE. Again, you see this, I'm going to move my little screen here. You can see this increase. So if you go to the top line, the blue line, this is all opioids. And if you see the yellow line, that's synthetic opioids, such as fentanyl. So you can see that spike again, right, that we talked about with the US steps that we just showed before. We saw a little bit of hope maybe in 2022, but we're seeing a rise again in 2023. There's just still way too many deaths. The other thing I would like to point out on this is you can see the bottom lines, the gray and the orange, representing methadone, and the natural, which are the prescription overdoses, that those have tapered down, that we're not seeing a spike in overdose deaths for those two. So just similar to the United States, here's some overdose data for Colorado. You can see a 4 times increase really since 2019. And a fatal overdose death occurs every 4 hours, 45 minutes, and 9 seconds in Colorado. Let's give me a minute to look at this, because I think sometimes we get really focused in on our own county. And I find it interesting to think about us as a state. So the darker the color, the higher the overdose rate, with 19.1 being the average in Colorado. So it's probably tiny for you, but you can see Adams on there and Arapahoe. Anybody have anything they want to chat about there, or in Douglas County, sorry? Anything curious or interesting? More males than females. And then we really, really need to do a better job, like we all do in health that we work in, of concentrating on these subpopulations. It's these same old populations that we deal with in all of the other types of public health work that we're doing, that are seeing increases in concerning things impacting their health. So an increase of 44% for Black people in 1 year, reported by the CDC, in overdose deaths, and an increase of 39% in AIAN in 2020 in overdose deaths. Same thing in Colorado. I don't think we have the same 44, 39%, but these same subpopulations are seeing these large increases. I see a hand.
Yeah, do you do you know why, like some of those states up in Moffat County, I mean those counties, and down south, why it's so much worse?
Bring it out to the group. Does anybody have any thoughts? Because I know there's a lot of health people on here. Do you have any guesses what that might be? Because I feel like it's all related, lack of resources.
One component could also be if there's a smaller underlying population, a smaller or not smaller, but a couple number of deaths could really increase the rate. When you do have a smaller population in those counties, that could just be one thing going on.
And these are, I'm not a data person, but these are per 100,000. So it's adjusted that way. One thing I know down in the Southeast is that there's an increase in prescription painkillers still happening there. And sometimes, again, it's based on not having enough physicians down there. It could be based on industry, right? Where there are farming communities that may be having more pain issues. There are a lot of reasons, but I think mostly what we see is just inequities, basically, in these counties where people don't have the housing, or they don't have food, and they struggle in their mental health, and just kind of this cycle of pain, and then not having the response that we need in these areas. So what is fentanyl? The one we're talking about is the illicit fentanyl. I know you all know that there's illegal fentanyl. We're not concerned about that one right now. Fentanyl is involved in 66% of all overdose deaths. I think that's actually gone up since this slide was made. It's cheap, it's hard to detect. It's mixed in with all kinds of substances, right? You've heard this before, you don't know what you're getting. You might think that you're taking an oxycodone, and it could have a very tiny speck of fentanyl. It could be pure fentanyl. And again, the strength 80 to 100 times stronger than morphine, 50 times stronger than heroin. It's pressed into pills, powders, crystals. And over here on the right side of the slide, you can see on the tip of that pencil, that's a potential lethal dose of fentanyl. So it's just a very tiny amount. And the other image shows a lethal dose of fentanyl compared to heroin. And probably some of the harm reduction people will talk about, maybe they won't, but maybe they will if I say this, just this chocolate chip cookie effect, right? That you can split a pill in half and you don't know if there is fentanyl in there. You could have all of it in one side of the pill and a little bit in the other side. It's just, there's just no way for you to really know how much fentanyl is in your pill. So,
And Jennifer, can I
yeah.
ask a quick question? So my thought of talking about this was around testing. So then that makes tests not always reliable, because if you're testing a
Yeah.
part of a pill that doesn't have the fentanyl in it, then it's really not indicative of what's in the whole pill. Is that
Yes,
true? Yeah.
that is accurate.
Yeah.
Anybody from harm reduction want to expand on that? Other than that is accurate. We do have fentanyl testing strips, and there are ways for people to check their drugs, but that definitely is one of the concerns. So you can see here on this slide, these are some DEA photographs of some of the meds that they have taken in and analyzed. And, it's hard to tell the difference between a real pill and a fake pill. And we're seeing fentanyl in Xanax. We're seeing it as looking like an oxycodone. We're seeing it in Adderall. We're seeing it in cocaine. And, this is our concern over not just adults, but young people as well. And we're seeing these same types of increases in overdose rates with young people. When you think about, a student saying, hey, take this Adderall, take half this Adderall. Those are the kind of conversations we need to have with young people, that you don't, and all of us, you don't take any medication unless it comes from a bottle that was prescribed to you with your name on it, exactly as directed on the label. It is just not a time to be experimenting or just giving something a shot. I can't stop young people or anyone from not using drugs. That's not what I probably have the ability to do. But if I can keep them safe by saying, this is just a really, really crappy time to be playing Russian roulette with your experimentation, that's really what my goal is. The next slide. So the polysubstance use is this fourth wave, and we've just been talking about this recently, that we don't talk enough about it. Polysubstance use is a huge concern, and something that we're seeing really across the United States and in Colorado. And it means that people are using more than one drug, often without the person's knowledge. And they can also overdose because of a combination of drugs. And so we just got this recent data from CDPHE. If you want to just take a minute to look at it, because I hate when people rush through data, right? Take a minute to look at the lines. And what do you see? So you see methamphetamine on the rise as far as drug overdose. And if you look at the orange line, this is methamphetamine with mention of fentanyl. And then the gray is methamphetamine without mention of fentanyl. So here's an example of this polysubstance use. And, we're talking at regional and local levels, like, what does this look like in a harm reduction agency? What does this look like in our response, in our education? So it just continues to change. I wish I could say that this was all, getting better and on the decline, but the market just continues to change. But we're all here to help and work together. The next one. So the response to the crisis, we've been responding to this crisis for a long time in very many different ways. I'm just talking about kind of the high level of what we're doing in Colorado. So people here on this call, right? They come from public health agencies and nonprofits, and schools are working in prevention. You're going to learn later about the opioid abatement councils in each of the counties. We have people here that have been working in harm reduction agencies, coalitions, substance use prevention coalitions, individuals and community members, treatment and recovery organizations. It's really a collective impact model, which I know you all are familiar with, that we all have to do this together. We all have different roles, different experiences. You put on your hat and do what you can to help mitigate this crisis. But one thing that has happened from the experiences we had in the 90s with the overprescribing is these settlement funds are starting to come in across the United States. And in Colorado, we're receiving approximately $750 million in settlement funds from pharmaceutical companies and pharmacies, some of which you can see over here on this left side of the screen. And there are 19 regional opioid abatement councils across the state, and each of these councils gets this bucket of money, and they get to determine what they want to do with that money. It's based on some principles, it's based on evidence-based strategies, it's based on advisory groups and groups of people that come together and make these decisions. And if you want to learn more kind of high level, actually, it's not even high level, it goes deep in. If you go to the coag.gov/opioids, there's all kinds of really interesting maps in there where you can touch on a county. It will tell you the dollar, what strategies they're using, who they're funding, and how to get involved. The next one. So here's an example of some of the strategies. I always think too, like, well, what are we doing, right? What can we do? Here's some examples. So naloxone to reduce opioid overdose and other harm reduction measures, which we'll talk about later. More MAT expansion, so medically assisted treatment for people who are going through opioid disorder, and the medicines will help them in their recovery. So treating the opioid use disorder, we have big concerns over workforce shortage, which I know you all can commiserate with. What can we do about that? How we can engage our peer recovery coaches, the importance of connections to care, screenings, your workplace, your faith community. There are all these places where people feel connection that really can be involved in our response. Supporting people in treatment and recovery with these wraparound services, recovery housing, then these subpopulations that we really should be focusing on, treatment for incarcerated populations, transitioning out of the criminal justice system. I think the stat is something like there's a rate of, it's like 12 times higher of a chance of dying of an overdose for people who are transitioning out of the criminal system because they haven't been using these substances. And so they're going out with a less tolerance and maybe using the amount they were using before. Same thing can happen if somebody was in recovery and is back out and using and connecting to those same people. And then addressing the needs of pregnant or parenting women and their families, including babies with neonatal abstinence syndrome. And then prevention programs and campaigns. So what can we do to help with our providers and their education? Safe disposal and storage is something we can all learn more about, is where we keep our medicines, where we can take them to get rid of them when we're not using them anymore. School-based education can be very upstream. It can be the social emotional learning that we talk about. And it can also be looking at risk factors of young people that are starting to use substances and having these conversations. And not all the coalitions that you have in your counties. Next one. And then finally, here's some resources and campaigns. I always feel like when I hear these things and I think, well, what can I do? There are so many media campaigns. Some people love campaigns, some people don't love campaigns. But for those of you that think that this could be something that you could use in your organization, my contact information will be sent out afterwards. And I will also send links to all of these resources. But we have a lot of really great new campaigns that have come out with some of this additional funding that's coming into the state. Connect Effect focuses on young people, middle school, high school age youth and their parents. It's all around positive social norming and connection between young people and having conversations and peers helping peers. This new one on the right is Take Meds Back. The easier way to keep pets safe is starting with your medicine cabinet. So again, it's this safe storage. Everybody loves a dog. I see Julia's heart's bleeding. And then Last Night Out is, that's a Keep the Party Safe campaign that's really focused on harm reduction, saying, hey, you're invited to the party, but fentanyl is not. And the campaign talks about how to use naloxone, where to get naloxone, how to keep yourself safe and your friends safe. And then Lift the Label, if you're not familiar with that one, that really focuses on anti-stigma and kind of normalizing the fact that you probably know somebody who's going through substance use disorder, or you might yourself. Let's talk about it and figure out how we can help each other. And that's all I have for you today. So just some takeaways of things you can do. Again, you can join one of our work groups. Also, if you go to our website, you can sign up for a newsletter that comes out with some really good information. I think it's every other month. Work on reducing stigma, sharing some of these resources we talked about today, and building connections and supporting your community efforts. So I appreciate your time.
Jennifer, thanks again. This is great information. We're going to speak a little bit more around the opioid abatement councils.
Hi, everybody. I'm Dr. Kelly Weidenbach, the Executive Director of the Adams County Health Department, and I'm also serving as the Vice Chair of our Opioid Council in Adams County. And Jody and I work very closely with one another along with Peter Padilla, who's our chair of the council, and work very closely to oversee our council work. And yeah, I feel like I will turn it over to Jody because she works for Rocky Mountain Partnership, and the Adams County is the fiscal agent for the Regional Opioid Council in Adams County, but we have chosen to sort of staff through RMP, the council and the facilitation. And Jody and really all the work and facilitation has been on RMP's side. So turn it over to you.
The Attorney General's office really, through that state MOU, there's a lot up for local control. So I believe that every council looks a little bit different. So you can see, like for ours, that there is, oh, Racquel, did you want to talk about this?
Yeah, I was like, I may be able to help you. So I'll introduce myself in a minute because I'm part of Douglas County, but my name is Racquel Garcia. I'm actually appointed by the attorney Phil Weiser to the State Opioid Abatement Council. So I have a voting right on that council. And so that is where all the money comes in at the very top level, right? And then we set out priorities according to what the national standards are for the opiate abatement councils across the country. We just were doing a lot of collaborating with that down in Georgia. And then it breaks out further down to the regional. But I also like to say that too, because I'm also a woman in recovery and also have to be a biracial woman. So I think it's really important for people to know that there is a female woman, biracial woman who's in recovery that sits at that top, one of those top tables that watches that. So I think it's important for you guys to know that.
Yeah, thank you. For the regional or the ROAC, the regional councils, and Racquel, I don't know if you know the answer to this, but are there required or just recommended seats for the different ROACs?
They have to be government seats. That's as a peer, I wish that would change. I'm gonna try to get that across. It has to change across the country, though. It can't just change in one.
Yeah.
It had to be on the original MOU, but yeah, it definitely has to be government. It's government officials that have to run that money.
Yeah, so either staff or elected. So you can see for Adams County, which is Region 8, we have county commissioners. We have 2 city representatives, as Kelly mentioned, Councilmember Peter Padilla's City Council for City of Brighton, and then Mayor Pro Tem of Federal Heights. We have the Human Services Department, Dr. Weidenbach representing the Health Department, the District Attorney's Office. We have a local law enforcement representative. So Chief May from City of North Glen, Police Chief, connects back with other law enforcement peers, but represents them here. And then we have Chief Judge Kyle Seedorf from the 17th Judicial District. That's a really great point about lived experience, Racquel, because that's something that even our network more broadly has asked questions about, but because of the federal guidelines being what they are, we've had to get creative in how that lived experience really shows up. And I'm proud of Region 8. There's a lot more work to do, but we can share a little bit more about
yeah, you have to be creative about it. That's actually one of the things I'm talking to them right now. Jamie Feld and I were at a baseball game the other day talking about how do we do that better. And so the state COAC, I'm going to put forth some recommendations actually on how councils around the state can better incorporate the lived experience. Especially those from minority populations.
Yeah, it's critical. And again, just maybe to brag on Adams County, I think that the desire from the folks that you see here on the council to have everything that they do be really not only informed, but guided by that lived experience as well as content expertise is super strong. So on the next slide, well, let me first and foremost say we did a lot of infrastructure building right up front, not only bringing these folks on the council together, but also with a opioid abatement data hub or dashboard that's linked in this presentation. And I can pull that in the chat in a second. I'm going to be bad at multitasking, but there were one first cycle of round of funding that went out in 2023 that you can see here. And it was really broad. There was a big push from the council to say, we want to do the due diligence of filling gaps and making sure that we're building on what works. And at the same time, people need this money now. And so we really work to get the dollars that you see here, that 2.7 million, out the door as quickly as possible. This information is all on our data hub, because what part of the role that Rocky Mountain Partnership plays is not in just facilitating that council, but in supporting grantees to really map their impact, KPIs on a quarterly basis. And so you'll find that on our dashboard. On the next slide, you can see that, I believe, kind of where we were in the funding approach as a region. The council wanted to do another cycle of funding. Some of those grants were extended. There were some new grants made that I'll share in a second, but they held on to about $3.5 million and said, we really actually want to understand more deeply what are the gaps and opportunities within our region, and not necessarily only look at funding who's already here, but maybe who's not here in terms of service providers and needs and what that looks like. And so we convened a work group that I'll talk about in a second that is actually going to be meeting with our council next week to do a couple of things. So that funding, there's kind of TBD a week from now and what's going to happen there. If you go to the next slide, you'll see there's 2 pages here for amounts awarded for this 2024. And go to the next slide. I think it's just about $3.8 million. And I said, this is a combination of grants being extended and some new grants getting out the door. These metrics haven't started being tracked yet on the dashboard, but they will be. Awesome. Okay, so the key driver work group, and I do have Ashley Ettinger on the phone here as a phone a friend. She's our senior director of strategic support, so has really been working very closely with what we're calling a key driver work group, but really we see is going to be transitioning into kind of an advisory committee for this council. Their role is to support the council to align funding to address those persisting gaps. And by doing things like identifying the metrics that make the most sense to look at, recommending a countywide goal. This is something that is really centered to the Rocky Mountain Partnership way of working, which is what are we working towards? How are we measuring it? Not just how are we going to get somewhere, but where do we need to get? And so one of their deliverables that they'll be sharing next week is that draft target that I'll be able to share with you in just a second. But also really digging into the quantitative and qualitative data to make funding recommendations, not only for that 3.5 million that we still have like ready and available to utilize as a council, but moving forward so that it's not always a getting on the wall approach, but really strategic and aligned to a target that is one over time that we'll be holding accountability towards making progress towards. And I believe the next slide says who's on that key driver work group right now. We have a combination of folks with content expertise from the health department, lived experience, law enforcement, other direct service providers that you can see here. Jennifer, I don't want to pick on you. If you have anything to add as being part of that work group.
The only thing I will add is kind of what Racquel was talking to is I participate in a lot of these councils based on my region. I think I have like 8 regional councils that I hang out with. And all of these counties are doing it differently, but they're all doing a really good job of saying, we need advisors. We need people from all different sectors of our community coming together to make these decisions or to report to the people that are the voting members around the money. So I do think that, and we're all getting together and talking about best practices around it. So I have hope that this is just going to continue to improve.
Yeah. Absolutely. On the next slide, you can see this is draft. Our council hasn't even seen this yet. They'll see it next week of the recommended target. And this is really starting with let's have a decrease in overdose deaths for Adams County. And this has taken us a long time to get here and really reach consensus with all of the myriad of different stakeholders that are engaged, but really proud of the work that this work group has done to put this recommendation in front of the council. Unfortunately, I don't have funding recommendations to share with you all today, but those will be, like I said, public in a couple of weeks.
They are finalizing them literally this afternoon, just after this meeting.
So that's at the highest level, the focus of the Adams County Council. I'm happy to answer questions if there are any, or if there's anything, Joe, that you hope that we can speak to.
I think that was great. I think it's helpful to see what the councils do and where their role is. I think that was very helpful. Questions or comments, thoughts from others? Anything that's surprising you from what you're hearing today? Racquel, I know that we have a couple slides with your council. Did you want to speak on that? And I can share your slides.
Absolutely.
All right.
I will tell you, this is not my finest slide preparations.
I think they look great.
Thanks. They're kind of plain. I kind of am a.
Plain is good. We don't want.
I can be a little bit of a slide snob. Well, hi y'all. My name is Racquel again, right? Like I work in Douglas County region. I actually live in the Douglas County area also. So this is my home. So that was why it was really important. I recovered on the other side of the El Paso County line, but I always tell people county lines only matter to the people who govern them, not to the people who live here. So I feel like it's one big region to me. So, you know, we had 12 priorities. We were a little bit late starting in Douglas County for ours. We had 12 top priorities, detox, MAT, peer support. Our county already had a great CRT heart program where they partner alongside they combine a behavioral health professional with law enforcement to go alongside folks on calls. And so one of the priorities was to make sure that was allowed to continue and offered some additional hours. So that was a priority for our region. I'm going to say, like, I'm really proud of Douglas County in their proactive efforts. Yeah, co-response. Thank you so much for that, Jennifer. I was like, what is it? I know all these fancy terms. I'm a street girl. So I tell everybody my tattoos on my neck say holy and hood. So I'm still trying to get with the lingo of the government. But that CRT program is pretty awesome. It's been really amazing to see that grow. And we were able to expand that. So that co-response program got some priority funding. I am really proud of Douglas County. I really do believe sometimes here our biggest challenges might be our community. It's not actually our government. Very forward thinking. You'll kind of see some of that in some of the things we'll go through in a moment. Youth prevention is really huge in our community. So we have a priority of youth prevention in Douglas County. Transportation, because we have none. So Douglas County is in a desert. It is a transportation desert, only to be getting by car, Uber, that type of thing, which can be a challenge, especially when you're thinking about MAT support services. When we don't have it, then how are people in our community going out to get those support services when we don't have MAT and public transportation in our own community, right? So there's a big issue. And then also case management. And then we had some administrative priorities for ourselves. Next. So what are we working on? Our council just went in and did a bunch of, we had our RFPs go out. We had all of the submissions put through on BidNet, and we have not made any announcements yet, but we're still approving the grantees for the above priorities. We did have quite a bit of scopes come in, so we're working on that behind the scenes. We had to do some re-interviews and things like that. In addition to the priorities outlined that we put before, we also voted to fund 2 additional priorities on March 7th, and they're currently developing the scopes of work specific to each of those. And one of those was actually really amazing. We have an amazing Chief Duffy on our council. He is just this wonderful man who always felt like he was kind of alone out here in Douglas County, feeling like nobody was helping him. He really spoke up about his needs in the community as the chief. And then also, you know, that this need for emergency operation funds for SUD nonprofits in the region, when, you know, governments are not, you know, the upper governments or state entities are not able to do what they say. We can't afford for our small nonprofits in our community who hold our community together to not be able to make payroll and things like that. And so as an organization, they made a decision, or as a group decision, that we should have some funds so that SUD services, if they're struggling, can get their payroll taken care of or something like that. So we're not frozen by services because of lack of state support. And a communication awareness and anti-stigma campaign that we're going to do as a COAC or as the ROAC, because Douglas County has high stigma. We have a community that doesn't speak about that. If it's the richest county in the state of Colorado by per capita, richest county in the state of Colorado. So with money comes more money, more problems is what I like to tell people, right? So more money, more problems. And so we have to have large conversations too, in bringing conversations about substance use disorders even to the surface in a community that does not acknowledge them. So I really love that they made that a priority, because you'll see in the next slide. I'll show you that, you know, we are working on harm reduction. I can say, honestly, I wish it was more in Douglas County. I'll be bold in that as a peer and someone who advises the council that we didn't make it a priority. But Douglas County law enforcement carries Narcan. I can also tell you that every single officer inside Douglas County Jail is required by Chief Duffy to also keep 2 on person. So it's required. So I love that he does that. And he does that, I'm just telling you, like, in a community that doesn't talk about it, right? So that's really wonderful for our law enforcement to do that. The council identified harm reduction as a need in 2023, but it did not emerge as a priority for the first year of funding. And then when the group is ready to prioritize to determine how to spend funding from years 2 and 3, we'll readdress the interest in supporting harm reduction efforts. For us too, high use of alcohol use disorder in our region, which also backs secondary to the medication juggle, and opiate use juggle. It's a lot in our region. That's actually was my background in my substance use. So we're gonna have to have like those conversations and start talking about harm reduction a little bit more. And I think that stigma campaign first will actually help with that. And then there are few nonprofits in the community. I'm actually the only one actually as a nonprofit SUD, the only peer recovery in the entire county that provides education and harm reduction. We have a walk-in center in Castle Rock where folks can come in and get naloxone, so no questions asked. We do educational meetings 3 times a year. We host overdose prevention. We host a lot of things in the community, but again, right, very large community. I'm still the only one doing it. So we consider ourselves Hard Beauty part of that harm reduction plan for Douglas County. And I'm going to be honest, I don't know numbers. I just grabbed this slide from the wonderful people at Stedman. I love Rhiannon, and I was like, give me some stuff to share. But it just shows the funding and what we've requested and the costs. It's going to show you that the emergency operations for Douglas County nonprofits, that's really what they're looking for. The communications and other regional planning and implementation needs for the area. And then we now just started building out a couple more extra work groups. I didn't get the name of them. I missed the last meeting for all the work groups that we're creating. But one of them is specific, is going to be a work group around the stigma and communications campaign to see how we get this information out to our community. That's it.
Thanks, Racquel.
You're welcome.
That was great. There's a lot of momentum happening in Douglas County. That's really great
It's getting
work.
there. It's getting there.
Yeah. Thanks for mentioning about the priorities. Can you say a little bit more about the transportation piece? I know that transportation is a challenge in general, but more so in Douglas County. I mean, what are there more innovative ideas for around transportation? I mean, that's a tough one, transportation.
Yeah, we have no recovery housing either. So we don't have one recovery house and no transportation in the entire county. That will change in the next 60 days. We'll have a recovery housing coming to Douglas County Women and Children's Housing starting. But again, right, people said, well, why would you put recovery housing in a place with no public transportation? I said, because we live here, because you can't make that a reason why my mamas and my people don't get recovery because we don't have transportation. Well, then, I went to a grant and asked for a minivan, like, give me a van. I will get folks to and from. I will tell you, 70% of those who are incarcerated inside Douglas County Jail don't live in the county. And so that requires some creative, innovative work, even with the JBBS team who works inside the jail, the jail behavioral health team inside the jail to make sure that everybody gets back out to their communities. And they're often driving people in vans. They can be driving. One of the ladies said, I will go from Douglas County all the way to Alamosa to have to deliver someone back to their community, because I think there's been a stigma that we don't want people in our community. If we don't allow public transportation into Douglas County, they can't come. The bus, if you notice, the RTD stops stop at Lone Tree. It'll never make it to Castle Rock. It's as far as it goes as Lone Tree. And then the bus staying that actually is the RTD bus will take you from Denver, but it does not stop in Castle Rock. You actually can't get off that bus till you hit El Paso County in Monument, Colorado. Why? They don't want people coming through. Why? Right? Now think about it, right? If we don't allow people transportation to come, they may not come to the community. So it's required us to do grant funding as far as like making sure we have Uber money. We are grant funding for Uber money because my folks cannot get MAT in my community either. They have to sometimes go to the El Paso County line. We have to take them over there for them to come back. So it's been a challenge for our folks.
Yeah, for sure.
Can I just add, do you guys understand now why it's so important that Racquel is here? Everything you just talked about with transportation, unless you've lived it and you're working with people that have these experiences, you wouldn't know it.
Yeah, and then think about how many people are mandated to do this. So like you have to go. If you start MAT or you're starting some medicated assisted treatment, you have to go every day. That's a constant responsibility. So then let's not make that, you put that burden on someone, right? It's an unrealistic expectation that myself in Castle Rock is gonna be able to go every day. And let me add that I'm a mom with 3 kids on that. Every day I'm going to be able to take myself from my community and go to the next county over to get medication. That seems very unrealistic. So, for Douglas County, we are looking still for a good proposal for MAT. So if anybody has and knows of any OTPs in the community, like that is something that we would like to see in our community. And how can we do that collaboratively in Douglas County? We're still looking for that.
Racquel, is the awareness campaign that you're talking about targeting the stigma of MAT just generally as a viable treatment?
We're going to talk about even substance use disorders in general. Like we have to start talking. I mean, people were really shocked when I moved to Douglas County. They said, well, who did you ask permission to set up a recovery center? I said, well, I didn't realize, who was I going to ask? I didn't have to ask permission because it's here. And so just people were shocked that we would set it up. We've been open almost 2.5 years. We have people walking in our doors. Our community's growing, so when we talk about stigma, we have to talk about that we even have an issue of substance use disorders in this community. We have to even talk about it first. And then we will also weave in, how do we support our community? I think it's going to be like a tiered approach. Obviously I'll be in those conversations because I live in a small community too. So you have to be really delicate in small community and how you come in here. You cannot just walk into a small community and tell them what to do. They will pitchfork you out. I've seen it happen. I've watched an OTP get pitchforked out of Monument, Colorado, because they did not come and engage the community in those conversations. So that's another part, right? Like when you're doing this work, you come in, co-create with the community and ask them what their needs are and you come in like a lion, man. Small town will, like I said, they will pitchfork you out.
Thanks, Racquel. Thanks for being this voice, such a welcome voice and advocate for what's needed there. And it sounds like it's working. It's just a lot of work, but it's incremental steps. And thank you, because
and it's home. It's home. It's where I live.
Right.
It's my home. It matters to me. I live here.
It's your community. Sure.
It is my community.
Yeah. Thank you. And thanks for kind of giving us a beautiful segue into harm reduction, what that is. I'll turn it over to Kit and Elicia.
Perfect. Thank you, Joe. Hi, everybody. Again, my name is Elicia Chacon. I use she, her pronouns, and I'm with the harm reduction program at Arapahoe County Public Health. Kit, do you want to introduce yourself?
Yeah, hi, I'm Kit. I also use she, her pronouns, and I'm a health educator with our harm reduction program. And like we figured out, we don't have anybody from our Opioid Abatement Council with us right now. And I believe that Adams County is going to go a little bit deeper into what harm reduction means. But as like a little overview for our presentation, Elicia is going to give us a quick lesson.
Yeah, so we actually, like Kit said, we don't have a slide specifically stating what is harm reduction, but basically harm reduction is just a set of strategies and principles that are used to reduce any negative consequences associated with a behavior. And so harm reduction is very prominent with like sex and substance use, but that doesn't mean it's exclusive to sex and substance use. We can think about harm reduction and COVID, wearing masks, testing regularly, isolating when we are sick. With the weather changing, we can think about wearing sunscreen when it's really sunny out, drinking water on a hot day, just anything to keep people safe from a potentially harmful behavior or situation. And so, like I said, with us, our program works specifically with folks that inject drugs and use drugs. And so anybody that might benefit from our services is welcome.
So a lot of the supplies that we hand out are specific to folks that use drugs, but we do have some just general safety items, including Narcan and sexual health supplies like condoms and lube. So first, we've got our needles and syringes. We have a whole bunch of different sizes. Folks prefer different sizes for different things, especially people who have some sort of like hormone therapy that in which they have to inject. They need a much larger needle than someone who is injecting methamphetamines, for example. And our program is pretty lucky because we're able to do just a needs-based distribution system, which a lot of other programs a client has to turn in the exact amount of syringes that they can receive, but we are able to give folks as many as they need until the next time they can get a clean and safe new supply. Next, we have Narcan / naloxone. I'm sure many of you are familiar with that. We give it out to so many folks and so many organizations. If you all want any and don't know where to get it, come talk to us or Adams County. I'm sure we have so much and we love giving it out. Fentanyl and xylazine testing strips, those are used to test any substance that someone is using. And we talked a little bit about fentanyl, which is a synthetic opioid, but xylazine is a horse tranquilizer that is showing up more and more in the drug supply. It kind of started over on the East Coast in like Philly and Baltimore and stuff. And the really dangerous bit about it is that it causes wounds that do not heal. And because it's a vasodilator, it constricts the blood vessels, and the nutrients needed for those wounds to heal and recover are unable to reach them. So folks that use this substance often don't know it's there. Many of these folks do not have access to reliable health or medical care. And we're seeing a lot more like amputations and like just huge, horrible wounds on folks because of something they didn't realize was there. We have works for drug preparation. These are mostly works to inject drugs. And we give these out because sharing any of these items can lead to spread of communicable diseases, specifically HIV and hepatitis C. And we also give out a bunch of different kinds of sharps containers to prevent litter and accidental needle sticks. Next slide, please. And we also have a couple of kits that we give out. We've got our snorting kits, smoking kits, boofing kits, and then just wound care kits. So again, all of these items, if folks are sharing them, they may share and transfer communicable diseases between each other. So we like to give out these items to prevent that. And we also give out items like, for example, with snorting, if you do it very often without like without properly taking care of your nose, you can get some bad wounds and like holes in your septum for smoking or through snorting, sorry. Which is why we provide things like petroleum jelly and things like that. Boofing kits, that's something I want to talk about because not a lot of people know what that is. So boofing is another name for booty bumping, and it is a rectal administration of drugs. Folks have reported to us that it is like the most similar to injection use, like the most similar feeling to injecting without actually injecting. So it's a harm reduction strategy that folks can take a step away from injecting and maybe switch to a different administration.
So the other kind of half of our program is we offer free testing for HIV, syphilis, hepatitis C, and then gonorrhea and chlamydia. As Kit mentioned, folks are at risk of these various communicable diseases, especially if they are sharing or if they are engaging in maybe some sex while they're using. And so we offer this to folks while they come in for any of their supplies. Everything is, like I said, free. And so they don't have to worry about the cost or trying to go through insurance or just trying to figure out a way to get themselves tested. So we offer a few different tests. The HIV Insti is a rapid 1-minute antibody test. And so we're able to collect a blood sample and get somebody's HIV results within 1 minute. And so that is a really great quick way to just, engage somebody, assess what their status is and see, how we can help them get them into HIV treatment if needed. We also offer a dual HIV syphilis test. So again, we collect their sample, we'll get their results within 15 minutes. And this is a really great tool because syphilis has gone up in the state, and congenital syphilis, I think the statistic was like it's gone up over 400% in the last couple of years congenital syphilis. And so being able to test for both of these at the same time is really great and just helps to, reduce the burden of infection and keep those rates down. We do also offer some incentives specifically for syphilis testing. And so we can give out gift cards to encourage folks to get tested and to seek treatment if anything comes back reactive and positive. We also offer the Hep C test, another rapid test. They'll get their results within 20 minutes. Injection drug use and sharing equipment is like one of the major risk factors for Hep C. And so being able to offer this to our clients is really fantastic. We actually just ended a program with Denver Health where they were in our space offering confirmatory blood draws and telehealth visits for treatment for Hep C. Unfortunately, that ended, but it's a really great way to connect folks to treatment and make sure, again, folks are getting taken care of and we're reducing the spread of these diseases. Chlamydia and gonorrhea are slightly different. So we will collect a urine sample or a swab depending on the kinds of sex they're having. And so when we collect those samples, we send those off to the lab and we'll usually get those results within a few days. It's a really quick turnaround for the most part. And again, we're able to link folks to treatment and make sure they can get their medications and make sure everything is all taken care of. Again, everything's free of charge. And we have a lot of different partners because our harm reduction program doesn't directly do treatment. We will just refer to treatment and try to link folks to the providers. So locations, we are primarily in Arapahoe County. There are times where you kind of are just across Colfax and you're in Adams County, or you might be down Colfax a little bit and you're in Denver County, but primarily we work in Arapahoe County in Aurora and Inglewood. So our home base, where all of our supplies are, where we are most of the time, is going to be in Aurora at Colfax and Chambers. We are here. We don't see very many clients here, but we're always here if folks want to come in and get supplies or get tested and just come see us. We do, I would say, like, if I had to put a number to it, like at least 75% of the work done, if not more, is community-based work. And so we're just in the community in so many different ways. It Takes a Village is a really great organization in Aurora. They do a lot of HIV work and work with a lot of LGBTQ people and people of color. And so they allow us to utilize their space to run our program. And so that is in Aurora off of Colfax and Lima. And that's kind of like a drop-in center. So folks can kind of come in as they please and as they need supplies and services. We also just launched our Prevention Point mobile unit in February. This has been a really, really great way for us to get folks connected to care. A huge principle in harm reduction is meeting people where they're at. And so we literally meet people where they're at by driving to just various places around Arapahoe County where folks might need our services. And so that includes, community partners such as the Safe Outdoor Spaces in Aurora, libraries, recovery centers, wherever folks might benefit from any one of our services. We like to be there and just set up shop. As you can see in the top, I think, right corner, that was us on launch day. It was really, really great. Hopefully some of you saw us in the media and read some news articles about us. And then we also offer everything except testing. This is more so our syringe service program. We offer through street outreach. And so we will load up our wagon and backpacks and just kind of find a spot where, again, we know folks are hanging out or where camps might be, and just kind of set up shop and distribute whatever folks need. And then we, again, partner a lot with community partners. And so we do various community events. Recently, we were at the Aurora Economic Opportunity Center event for migrant communities. We will be at some Pride events this year. And we just like to meet people where they're at and bring services to folks, especially because folks don't always know that our program is around and the services we have are available. And so just getting out there and talking to folks is key for us. And a really cool program we just piloted are kiosks. So we were able to partner with the COVID-19 team here at the county, and it's all kind of done through some COVID funding, but they were able to purchase old newspaper stands and kind of repurpose them, do some Arapahoe County branding. And we were able to supply them with COVID-19 tests, Narcan and naloxone, sexual health supplies, test strips. And that is going to be a really great way for us to reach people because, like I said, we're obviously out in the community all the time that we know folks might miss us and might not have the chance to interact with us, but we don't want them to miss out on those services. And so the kiosks will be in different centers. The picture kind of in the middle is that was our first placement for a kiosk with Safe Side Recovery Center in Inglewood. And so whenever folks come in for any of their services, our kiosk will be there. They'll be able to get whatever supplies they need as they kind of come and go. And then, we are placing a few more. We just placed another one at a treatment center in Aurora yesterday, and we will have some more coming very soon. So again, keep an eye out. Hopefully you'll see us on the news and see us in some media. Yeah, and that's it.
And here's another picture of the kiosk and the wonderful dog Shyla, who is there overseeing the kiosk placement and all of the supplies. She's a sweetie cutie baby. So if you're ever at Safe Side or near Safe Side in Inglewood, go say hi. The dog is great. And also the people there are wonderful. So some of our other services that we offer, presentations like this one, or we do Narcan trainings. We recently, within the last few months, got our home visitation nurses with Arapahoe County Public Health, all trained on Narcan administration, and then also they were all trained to hand out Narcan to their clients. So that was a great presentation that we did. And then our referrals, like Elicia mentioned earlier, we've got a bunch of connections to various treatment centers or like our sexual health clinic right upstairs, things like that. But we've recently hired a care coordinator who is going to be more focused on referrals and getting people enrolled in treatment and or like enrolled in a sober living house was one of the clients we talked with last week. And so that is currently developing, but we're really excited to offer more and better referrals. Next slide, please.
Yeah, and really quickly, our care coordinator is actually funded through some of the regional opioid abatement council funds. So that's one way that those funds are being utilized, which is exciting for us. So our impact, these are just some of the numbers that we put together for our impact of what our program has done in the last year. So in 2024, we've distributed over 546 Narcan and naloxone kits. That's to clients, community partners, at events, anytime anybody requests a Narcan or naloxone. And since initially opening as the Arapahoe County Public Health Department in January of 2023, we've given approximately 1,887 Narcan and naloxone kits. which is just really exciting for us. Most kits have at least 2 doses, and so we know oftentimes that folks are taking naloxone and giving that to their peers, their communities. And so we know, if we double this number, if everybody gave a friend 1 dose, that's over 3,600 lives that are potentially saved by utilizing Narcan and naloxone. Our program is still a little bit new. Like I said, a lot of folks still come in and have no idea that we've existed for the last year. And so on average, we see maybe around 19 new clients enrolled in our program every month. That varies, and I think it's increasing a lot more with our the introduction of our mobile unit. We're able to just see more people and meet more people where they're at and bring services directly to them. This year, we've had over 160 syringe access program interactions. So people coming into our program, specifically picking up syringes. And since beginning as Arapahoe County Public Health, we've had over 600 staff interactions. So again, people coming into our program, picking up syringes, whether it's for themselves or for others. We've had 15,000 syringes safely disposed of this year in 2024. So like Kit mentioned, we offer the sharps containers so that folks can bring back any syringes and get rid of them safely. So there's less syringe litter in the community. We give out a ton of safer sex items. So if any programs would also like free condoms and lube, reach out to us. We've given over 6,000 safer sex items. So condoms, lube, dental dams, internal condoms. Really quickly, I see a really great question in the chat. Do you have to be an Arapahoe County resident with an ID? No, you do not. We don't ask for any type of identification. Everything is confidential. And we've seen clients as far as like Chaffee County. We've had people come in from out of state back when we were Tri-County. And so we just want to see anybody that would utilize our services. The last 2 are specific to our test strip distribution. So this year we've distributed over 3,000 fentanyl and xylazine test strips to clients and community partners. And so, like I said, all of these numbers are hopefully going to continue increasing so that we have a ton of more connections with our mobile unit and just, more community partners. I did also want to mention we are able to distribute fentanyl and xylazine test strips to smaller community organizations if they work with people who use drugs or people that might benefit from having these test strips. So again, if that's something you're interested in, please don't hesitate to reach out. I believe the next slide is our contact information. So you can email. I would recommend email. The phone doesn't always work, unfortunately. But if you have any questions, anything like that, we're happy to collaborate.
Perfect. Well, yes. Thanks, Joe. My name's Ellen Velez. I use she, her pronouns. Again, I'm the Adams County Harm Reduction Program Associate Manager. I don't want to duplicate a lot of the great information that's already been shared today. So I think most of what I have on the slides is relevant. Just to go a little further in depth or reiterate again upon Alicia's point about harm reduction as it relates to substance use. So we really base our work in Adams County off of the National Harm Reduction Coalition's framework and guiding principles, but we view our work as a set of strategies aimed at reducing risks associated with any substance use. So acknowledging that drug use exists in our community, we provide resources to minimize any negative impacts while promoting health and the autonomy of the individuals that we're working with. We offer support and resources without any judgment or preconceived notions regarding the folks we're working with, and really let the people who are coming to us or people who use drugs guide the work themselves, create solutions that work for them, and just support and form connections within the community to get them connected to all the resources that exist, and trying to remove as many barriers as we can in the process. So just in regards to overdose data, Jennifer touched on this a little bit, but specific to Adams County, Adams County has had a significant amount of overdose deaths throughout the state. In the last 5 years, here's just some data. So 11% of the overdose deaths in Colorado occurred in Adams County from 2018 to 2022. In 2022, which is the last full year of data that we have, the county experienced 220 community members that died from opioid-related overdoses. A lot of the work that we talk about, a lot of focus has been placed on opioid-related overdose deaths, though. And in Adams County, we recognize the role that polysubstance use plays in overdoses. So a lot of our work is just focused around all substance use, regardless of the substance itself, and ensuring that people have access to resources, care, as much as possible within the community. So what do our services look like? These look very similar to what Arapahoe services are providing. So we focus a lot of our efforts on reducing disease transmission, so specific to HIV, hepatitis C, and STIs. We provide safe sex education, both in the community, schools, in a variety of settings, safe sex materials like condoms, lube, all of that information. We also provide HIV, hepatitis C, STI testing available at no cost. Similar, if not the same testing that Arapahoe provides. So for hepatitis C, HIV, and syphilis, we're able to provide rapid tests, which is great. Test results ranging from 5 minutes to about 20 minutes, which is really great for a lot of our clients, especially that are experiencing houselessness or harder to reach. We're able to offer a lot of that testing out in the community, bringing our services to them so that they don't have to necessarily make it to a clinic or follow up with test results, things along those lines. But we also do provide that chlamydia, gonorrhea, confirmatory testing that is sent out to a lab, and does require follow-up with clients as well. We work really closely with our sexual health team, which is great. So we can immediately connect people to treatment services for most of those test results, and able to provide a lot of these resources out of our mobile unit as well, and out on community outreach, which is amazing, just to remove that kind of third person or linkage to care component. We provide opioid overdose prevention education to the community. So we offer typically about like 3 to 10 naloxone trainings per month, and general opioid awareness education and prevention. This we kind of adapt based on the community, based on the folks attending. They're provided anywhere from out in more like rural areas of the county and Bennett to Brighton, and hosted at our sites in Westminster. We've met with a lot of businesses to provide naloxone trainings and education around this, local nonprofits, things along those lines. And then actually distributing naloxone, fentanyl test strips, and xylazine test strips, just to give the community more resources and education information to keep people as safe as possible. Syringe access services and safe use supplies. This really mirrors what Arapahoe is doing. So just making our services as available as possible. We have 2 mobile units that we take out on a regular basis to meet clients where they're at. We engage with a lot of treatment services, mental health agencies, bringing our services directly to folks, again, trying to remove as many barriers as possible. And then referral to other resources. So we have people with lived experience on our team. We have staff that speak Spanish and other languages. Our goal is really to make the connections and referrals to community resources for the services that we cannot provide directly. We partner a lot with other health services in our agency. So we work closely with our immunization team, As I said, sexual health team, a lot of other teams that can help fill in the gaps, but also really working on our relationship and rapport with other service providers in the community to help fill in the gaps. So again, similar to Arapahoe, these are just some numbers from our initial year. I will say that we have already reached, if not exceeded, a lot of these numbers for 2024 already. But Adams County Health Department really started our work in 2023 in like spring to summer, as we were really trying to get our health department and our team up and running. But even in that short period of time and starting from scratch, we reached over 3,000 community members through different outreach and education opportunities. We worked directly with over 180 unique clients for syringe access and safe use supplies, offering over 150 rapid HIV tests last year in collaboration with our sexual health team. Most of those were provided out in the community, so outside of clinic settings. We've provided over 40 naloxone trainings, reaching over 600 individuals throughout the county, distributing 2,100 naloxone kits, disseminating quite a bit of fentanyl test strips along with xylazine test strips, but that started really mid-summer. And then 7,700 condoms. Just a little bit of reference. I know we're running out of time now, but just so far this year, we've reached over 4,000 community members. We have 250 unique clients enrolled so far this year, and have performed over 50 HIV tests, 25 naloxone trainings, and have distributed over 1,500 naloxone kits and 3,500 fentanyl test strips and 4,400 condoms. So we're getting out a lot of resources into the community, and there's certainly a significant need. I think my last and final slide is just what our services look like, how people can get a hold of us. So similar to Arapahoe, we serve anyone that is interested in benefits from our services. All resources, services are confidential, do not require ID, do not require residency in Adams County. We have services available at 2 of our fixed site locations, one in Westminster, Monday through Friday, 8:30 to 4 p.m. So making our services as accessible across the board every business day of the week. And then in Commerce City on Mondays. We are hoping to expand those hours soon. And then we do outreach about 3 days a week. It kind of depends, typically street and mobile outreach about 1 day each, and then participating in a variety of community events and offering those naloxone trainings, meeting the community's needs with where they're at. And then our contact information is at the bottom of the page.
Ellen, thank you so much. So thank you all. I want to really thank all of our speakers and presenters today for the work you do and for presenting today. Thanks all. Thank you very much. Thanks, Racquel. Thanks, Jennifer, Ellen, Elicia. Hi, Jamie. Thanks, Jamie.